Imagine a medical whodunit where the culprit isn't some outside invader like a virus or bacteria, but your own body. It's a crazy scenario where your genetics and the environment violently collide, turning your protective immune system against your very own tissues. Well, that's exactly what we're looking at with systemic lupus erythematosus, or SLE for short. It's this profound autoimmune condition driven by rogue autoantibodies and immune complexes that can essentially attack any organ in your body. In today's explainer, we're going to decode this entire mystery. We'll break down exactly how it starts, how it physically manifests, and crucially, how modern medicine fights back. Here's our roadmap for the explainer. We'll start with the mystery of systemic lupus, then look at genetics and environmental triggers, and dive into the pathogenesis of immune dysregulation. After that, we'll explore the physical manifestations on the skin and joints, move into the kidneys, blood, and vessels, and finally wrap things up with therapeutic strategies.
Section 1. The Systemic Lupus Mystery.
So SLE is notoriously chaotic. It's a multisystemic disease, meaning it can hit virtually anywhere, from your skin and joints to your kidneys, heart, and even your brain. But who is actually getting hit the hardest? The demographics here are honestly striking. The prevalence of SLE is literally 9 times higher in women compared to men, mostly striking right during those childbearing years. In the US alone, the CDC estimates we're talking about roughly 204,000 cases. And the burden isn't shared equally either. It disproportionately impacts Black, Hispanic, and Asian women, who often experience not just a higher prevalence, but way more severe forms of the disease. This is a massive human experience we're talking about, with huge impacts on a person's everyday quality of life. Section 2. Genetics and environmental triggers. Okay, let's dive into this. How does a total systemic failure like this even start? Well, it perfectly illustrates what we call the two-hit hypothesis. Think of it like a loaded gun. First, the genetics load the gun. Science has identified over 150 susceptibility loci for SLE. We see genetic issues with nucleic acid sensing, like mutations in the TLR7 gene, and defects in how the body degrades cellular waste, like with the DNAC1 gene or certain HLA-DRB1 variants. But here's the thing. Having those genes usually isn't enough on its own. That's just hit number 1. Hit number 2 is the environment pulling the trigger. We're talking about things like intense UV light, which actually induces cell death and spills autoantigens, or cigarette smoking, silica dust exposure, and even viral infections like the Epstein-Barr virus. When someone with that genetic susceptibility encounters these exact environmental triggers, boom, the disease is activated. Section 3. Pathogenesis, the immune dysregulation breakdown. To really grasp this, I want you to think of this pathogenesis as a complete breakdown of your immune system's normal, everyday janitorial service. Let's walk through this cascading failure step by step. First up, we see this unusually high turnover of neutrophils. Those are a type of white blood cell. When they die off, they cast out these traps called nets, essentially dumping a massive load of nucleic acids and cellular debris straight into the body. Step 2. The normal cleanup crew, the macrophages, well, in SLE, they're defective. They just can't clear away this debris fast enough, so the garbage piles up. Step 3. All this overflowing cellular trash triggers sensors inside plasmacytodendritic cells. This causes them to pump out a massive amount of a signaling protein called type 1 interferon, which puts the entire immune system on absolute high alert. And finally, step 4. B cells lose their tolerance entirely. Whipped into a frenzy by all this chaos, they start cranking out pathogenic autoantibodies against that uncleared debris. These form immune complexes that get deposited in tissues all over, sparking massive systemic inflammation. Now you might be wondering, so what? Why do we need to know all this dense cellular science? Well, because understanding this exact sequence of immune failure is precisely how we target therapies to fix it. Literally every single step in that cascade we just went through is a potential target for modern drugs to step in and stop the inflammation before it destroys a patient's vital organs.
Section 4. Cutaneous and joint manifestations.
So, stepping back from the microscopic level, what does this actually look like on the outside? SLE shows up on the skin in 3 major categories. First is acute cutaneous lupus, or ACLE. This is where you see that classic butterfly or malar rash right across the cheeks. And a really key distinction here, it specifically spares the nasolabial folds, those smile lines around your mouth, which helps doctors tell it apart from things like rosacea. Next up is subacute cutaneous lupus, or SCLE. This one brings these widespread, red-rimmed rashes that are incredibly sensitive to sunlight. And finally, chronic cutaneous lupus, or CCLE. This includes discoid lupus, which causes these rough, scaly, circular lesions that can leave behind some pretty severe depigmentation and permanent scarring. Now, what's really interesting and heartbreaking about this slide is the distinct physical toll it takes. Just look at the severe impact of chronic discoid lupus on the left, causing patchy, scarring alopecia and permanent skin damage on the scalp and ear. Then, over on the right, you can see the extensive, red, scaly plaques of subacute cutaneous lupus completely covering the hands. These visuals are a really powerful reminder that lupus isn't just some invisible internal condition. It fiercely attacks the body's largest organ, the skin. Section 5. Kidneys, blood, and vessels. Let's move to the internal organs and see how this builds, because this is where SLE becomes truly life-threatening, especially in the kidneys. This maps out lupus nephritis, which is a major, severe complication. It's classified in stages, from class 1 all the way to class V. Basically, as those rogue immune complexes we talked about earlier get trapped in the kidney's delicate filtration system, the resulting inflammation progressively destroys the tissue. What you absolutely need to take away here is that class 3 and class 4, the focal and diffuse proliferative forms, are so severely defining of the disease that if a doctor finds them on a renal biopsy, that alone instantly meets the criteria for diagnosing SLE. That's how closely tied they are. And the assault doesn't stop there. The blood and blood vessels are under constant attack too. Patients frequently deal with a nasty triad of blood issues: anemia, leukopenia, which means a dangerously low white blood cell count under 4,000, and thrombocytopenia, which is a low platelet count under 150,000 that poses some really severe bleeding risks. On the vascular side, it's just as intense. The chronic inflammation drives premature atherosclerosis. That makes heart attacks and strokes a terrifyingly major cause of mortality, even in surprisingly young patients. We also see a lot of Raynaud's phenomenon. That's where the blood vessels in the fingers violently spasm in response to cold or stress. The fingers literally turn stark white, then blue, and finally red as the blood rushes back. Section 6. Therapeutic strategies and management. Facing an enemy this aggressive, how do we actually fight back? So the crucial point is that treatment isn't one size fits all. It's highly individualized and progressive. Because we know UV light is a massive trigger, rigorous sunscreens and anti-malarial drugs are the absolute baseline treatments for almost everyone. If the skin issues are stubborn, doctors will escalate things to topical glucocorticoids or calcineurin inhibitors. And for the really severe systemic issues, like that progressive kidney damage we just looked at, we have to bring out the big guns: oral immunomodulating drugs. Medications like azathioprine, leflunomide, and mycophenolate mofetil, usually just called MMF, are deploying to actively suppress that chaotic, overactive immune response and give the body a fighting chance. Which brings us right to the frontier of SLE research. We've mapped out the complex cellular breakdowns, those environmental triggers, and the devastating systemic impacts. But with over 150 genetic susceptibility loci now identified, it begs a pretty fascinating question. Are we moving toward a future where, just by reading a patient's genetic code, lupus can be anticipated, targeted, and entirely cured before the very first symptom ever appears? It's an absolutely profound thought to leave you with, as science continues to unravel the lupus mystery. Thanks so much for joining me for this explainer.